Since the initial submission of this abstract, we've actually collected a lot more data. So I'll be talking actually more about this newer data. So at this point, most of you know that 4D flow MRI has a lot of potential clinical utility. However, it's still very limited by long scan times on the order of 15 minutes for whole heart applications. In addition, 4D flow scans require cumbersome ECG gating. They also require some sort of respiration control. So usually you have a respiratory navigator following the motion of the diaphragm, and it only accepts data at end expiration. And similarly, most 4D flow techniques currently cannot investigate respiratory hemodynamics. However, we think that respiration-resolved 3D hemodynamics may be of interest because their effects have been documented in physiologic literature, and also their effects have been documented in Fontan patients and congenital heart disease patients with these abnormalities. They've been shown to have higher respiration-driven effects on cardiovascular flow. So Matthias Stuber's group has worked a lot on this 5D framework where you can have this respiratory and cardiac resolve 3D data sets. It's a free-running continuous acquisition for a set amount of scan time. It follows a 3D radial sampling pattern and is fully self-gated. And so the self-gating signals are used to bin the data for compressed sensing reconstruction. So previously, work on this has been primarily done with functional and anatomical imaging. So we actually partnered up with their team to go from 4D to 5D flow and add this respiratory dimension. So the purpose of this study is to evaluate 5D flow MRI, specifically in a clinical setting in a diverse patient cohort, and also look at the feasibility of resolving cardiac and respiratory hemodynamics in these patients. So the 5D flow framework is acquired on a transverse imaging volume. Each line here represents a repetition time. You can see interspersed superior-inferior projections, and so the data is acquired continuously for a set amount of scan time. The ECG is only shown for demonstration purposes here, and so we incorporated 4-point balance flow encoding to incorporate this flow sensitivity, and this was combined with a 3D radial spirophyllotaxis spatial sampling pattern. So the SI projections are then collected at the end and used to extract the cardiac and the respiratory signals, which are then used to bin the data into the respiratory, cardiac, and a velocity and cone dimension. And then the data is reconstructed using this multidimensional compressed sensing reconstruction, where you have a data fidelity term and then regularization along both the cardiac and the respiratory positions. And so we evaluated this technique in vivo in 20 adult patients with a variety of diseases, but most of which had some sort of aortic valve or aortic disease. And then, so of note, they were receiving a conventional 4D flow scan as part of their standard of care imaging, and this was of the thoracic aorta. So it was acquired in a conventional way, so grappa R equals 2, Cartesian, with respiratory navigator gating, resulting in mean scan times of about 10 minutes. In addition, we consented them for an additional 5D flow scan in the same time period, and this was, this was of the entire heart. This was with matched VANC and a mean scan time of about 8 minutes. So we bin the data into 4 respiratory bins, so based on this, as well as the patient heart rate, we achieved nominal acceleration rates of 36 to 76.9. Of note, we also acquired 5D flow data in 3 pediatric patients with Ferumoxytol contrast, and they had a few different varieties of congenital heart disease. So I think it's important to note that we also did a bunch of in vitro experiments because this is a much newer technique and newer protocol, and so we extensively validated this protocol and found good agreement beforehand. But for the purpose of this presentation, I'm going to focus really on the in vivo data. So here's a representative bicuspid aortic valve patient. Scan times were just over 7 minutes for 5D flow, and you can see that we've successfully resolved cardiac and respiratory motion. So we did conventional comparisons of the aorta, and so we looked at just the end expiratory phase for 5D flow, and you can see the streamlines match quite well between the two techniques. However, the systolic velocity maximum intensity projections, while they look very similar, you do note some increased peak velocity in the ascent aorta and decreased peak velocities in the arch and the descent aorta. We did some time resolved flow analysis as well and saw some underestimation in some of the later arch and descent aorta planes compared to Cartesian, but it looks quite good, I think. So over all patients, we placed 9, think it's running out of battery. We placed 9 planes, and so here you can see 3 representative planes over which we calculated net flow. So we found no significant differences between the conventional and 5D flow, except for in the root, where we did find a 18% relative increase. But otherwise, in all of the other planes, generally there was less than a 10% difference between the 2 techniques. We also looked at peak velocity, looking at the ascending aorta, arch, and descending aorta, and we found significant differences between the 2 techniques, specifically a 12% increase relatively in the ascending aorta and a roughly 7% decrease in the arch and the descending aorta. And so, of course, we had to look at respiration-resolved hemodynamics. To do this, for each patient, we segmented out the cable veins and their inflow into the right atrium. And we did this for all 4 respiratory phases because there's some motion between these phases. And so here's a systolic velocity maximum intensity projection for one patient. You can see differences as you go from end expiration, respiratory phase 1, to inspiration. You can see a decrease in peak velocity in the inferior vena cava and an increase in the superior vena cava, which is kind of interesting. And then we also did a planar analysis, and so we placed planes along these cable veins, and we did not find any significant differences in our superior vena cava veins, but we actually found significant decreased net and peak flow in the inferior vena cava in end inspiration compared to end expiration. And so finally, here's an example of one of the pediatric patients that we scanned with Ferumoxytol. And so you can see that with Ferumoxytol, this is actually one of the less nice data sets, I think, visually, but you can see improved blood tissue contrast compared to the gadolinium contrast that was used for our patients. And then we did some respiratory resolved kind of visualization and placed these cable planes again. And it's interesting because in this patient, you actually do note some pretty noticeable respiratory changes, but we're still looking at this with a bigger cohort. So in conclusion, 5D flow MRI is feasible in vitro and also in the clinical setting in vivo. It can depict respiratory resolved 3D hemodynamics within about 8 minutes of the entire heart, and this results in a significantly shorter scan time than conventional aortic 4D flow. We do note some underestimation in peak flows and velocities that might be due to the compressed sensing and regularization, and also this interesting overestimation in the ascending aorta, which may be due to some sort of background phase or averaging effects that we're not taking into account. So we think these initial results are promising. Of course, we need to do a lot more protocol optimization and investigation, maybe also of more use of Ferumoxytol, which creates this really nice signal. But I think this is promising. So I want to thank the group in Lausanne and also my colleagues and advisor and collaborators in Northwestern. Thank you.